recall, and today we are going to do the two topics like general surgery in first half and the CVTS in the second half. So let's start with the discussion on the general surgery. There are generally 10 to 12 questions from the general surgery, and can be a lot of more questions, but these questions can be overlapped with the other specialties also. So I have taken the purely general surgery questions, and we'll discuss on the general surgery part, as well as most of the questions are from the biostats or the epidemiology also. We will discuss all that questions in the discussion. So let's start with the discussion with the first question. So the question was the best research study for the correlation between the risk factor and the diseases. Out of the four options, one was the cross-sectional study, ecological study, cohort study, and the case control study. Among the four options, the confusing options are only two: a cohort study and the case control study. We can normally rule out cross-sectional study and the ecological study. So the correlation between the risk factor and the disease. So this correlation can be given by both the study, like cohort study also and case control study also. And the question was particular about the best research study for the correlation among these two studies, like cohort study and the case control study. Which one is the best? So for the cohort study will give the relations between the risk factor and the disease in the form of relative risk. And the case control study will give the correlation between the risk factors and the disease in the form of odds ratio. And we have to compare between the odds ratio and the relative risk, and which one has to be better. So the relative risk is far more better than the odds ratio for the correlation between the risk factors and the disease. And as comparing between the two study, like cohort study and the case control study. So cohort study is far better than the case control study, because cohort study is a prospective study and case control study would be a retrospective study. So cohort study is best or better as compared to the case control study. So among these the options, the cohort study will be the answer for these questions. So let's see the basic idea regarding the different epidemiological studies, like classifications, and how to compare between the two main studies on which the questions can be repeatedly asked, like cohort study and the case control study. So the studies can be differentiated on their basis, like observational studies and experimental studies. And observational studies are again classified on the descriptive studies and the analytical studies. And the experimental studies, among these experimental studies are the best studies as compared to the observational studies. And from the observational study, the descriptive studies are just for the hypothesis formulation. Analytical studies are for the hypothesis testing, and the experimental studies are the studies in which we confirm the hypothesis. So the experimental studies are the best among all the studies, or as compared to the observational studies. So on the analytical studies, there are mainly four studies, like cohort study, case control study, cross-sectional study, and the ecological studies. So let's see the basic of the cohort study and the case control study. So the cohort study, yes. So this is the normal flowchart of the cohort study. So just remember, the cohort study start at the population, or when there is a presence of risk factor is there. The peoples which are exposed, that is risk factors, is present, and the peoples with no risk factor is absent. So in cohort study, we divide the population into two groups: the populations with risk factor, population without risk factor, and we will study these two groups prospectively in a future and see what is the outcome or final outcome after so many years. Like some example, a smoker patient and another's are non-smoker. And we will study the development of lung cancer after 10 or 15 years, like that. And among the smokers or the peoples with the risk factor, and we see the outcome. So the patient among the smokers, how many people will get a lung cancer, and among the patient or population with risk factor, how many will not have a develop the lung cancer. And same for the risk factor, the patient with non-risk factor or a non-smoker. So the outcome, final outcome will be the patient will be having the lung cancer or a patient with a non-lung cancer. So in this study, we just make a chart for the formation of the outcomes. So the first we will see the patient with exposed group and non-exposed group. Another with a disease positive and disease negative. So the exposed group having the exposed people and have developed the disease are the A, with non-disease B, and this is non-exposed group with C and D. So from that we can calculate the relative risk. So what is the relative risk? Relative risk is the incidence among the exposed and the incidence among the non-exposed. So relative risk can be calculated by what is the incidence among the exposed. So incidence among the exposed will be the A upon A plus B divided by incidence among non-exposed. So incidence among non-exposed is like the appearance of the disease in the non-exposed. So C upon C plus D. So this will give us a relative risk. So this will give the relative risk. And relative risk, like if the patient is or the population, among the population, relative risk like among the smokers, there is a relative risk of 2 as compared to the non-smoker. It likes that, like among the smoker, there is a 2 times higher risk of developing a lung cancer as compared to the non-smoker. So this is about the cohort study. Next study is a case control study. In case control study, we go retrospectively. So initially we pick up the cases from the hospitals and the matching controls from the population or same hospital, and we go retrospectively. So the direction of study is from present to past, and from that we check the records or take a history from the patients or the cases and the controls, and make an inference like if the patient has already developed a lung cancer, and from the history we divide them into the patients with risk factors or the patient who had a risk factor like a smoking, and the patients lung cancer cases patient who had not a smoker or they have not a risk factor. Same for the controls also. So in that study, we just same like a cohort study, we make a chart like disease positive, like the patients with having the disease and the patient with not having the disease. And prospectively, we have compared that exposed and the non-exposed group. The disease patient who gives the positive history of the risk factor like a smoking, these are the A. The non-disease patient, and these give the positive history like B, and this is C and D. And for the cohort study, we calculate the odds ratio. Odds ratio is a cross product ratio. Though this is how we calculate the odds ratio. Odds ratio is AD upon BC. And odds ratio is just the it is not as good as the relative risk. So just let's see the comparison between the cohort study and the case control study. So cohort study is having it start when the only exposure is present, like only risk factor is present. In case control study, both exposure as well as outcome has been occurred already, and we give retrospectively to see the risk factor present or not. And there are various names for the cohort study and the case control study that can be remembered, like a cohort study is a prospective study, forward looking study, it cause to effect study, exposure to outcome study, and risk factor to disease study, like a prospective study, cause to effect, exposure to outcome. So in that, the advantage of the cohort study is that we can calculate the incidence, or this study can give the incidence among the exposed and the non-exposed, and it can also provide the relative risk. Other factors can be provided, like attributable risk, or population attributable risk. So in advantage of cohort studies also, there is a no recall bias in the, because we are going to prospectively study the population or the groups. And disadvantage is that ethical problems are there. It is a time consuming and expensive study. So strength of association is given by relative risk. And for the case control study, it is also known as retrospective study, backward looking study, outcome to exposure study, because outcome has already occurred and we are going looking to the backward. And another advantage of case control study is that it is useful for the rare diseases. And like that, we can study the rare diseases from the case control study. And another the disadvantage related to the case control studies is that it cannot measure the incidence and give only the odds ratio. It cannot provide the relative risk between the risk factors and the disease. And it has a recall bias also. And the final strength of association given by the odds ratio. So let's see the difference between the odds ratio and the the useful parameters obtained after the different studies. So we have already seen the cohort studies gives the incidence, relative risk, attributable risk. Case control study provides the odds ratio. And the cross-sectional study. Cross-sectional study is like a study at the particular time. In that case, at the population, there is a risk factor also, and there is a disease also. So it is a study at which we study the population at a point of time. It is also known as a prevalence study or a snapshot study. An ecological study is a study like it is very useless study. Like we collect data from one institute, like what is the nutritional status among the population, and we'll collect the data from the hospital, like how many patients are anemic, and like that we just correlate the to data. So it is not that useful. So, and among the relative risk and the odds ratio, the relative risk is it is a more accurate estimate for the strength of association between the risk of the disease and the risk factor of the disease and the disease. So it is calculated in the form of incidence among the exposed and incidence among the non-exposed, and the odds ratio will give the less accurate association between the risk factor and the disease, and can be calculated by AD upon the BC. So we have already seen the how we calculate the relative risk and the odds ratio. So let's move towards the next question. So among the different studies, which among the following is a best study design for the from the given options? So let's see one by one. So first is a randomized control trial. Another is a case control study. Another is a cohort study, and the last one is a case report. So just see the what are the which among the following is a best study design. So this is a straightforward question. We have already seen in that first slide of the discussion. The experimental studies are better as compared to the observational studies. And among the given options, the only experimental study was the randomized control trial. So that was the direct line question. So the options from the options, randomized control study would be the best options. And just see if there is another options like meta-analysis or systematic review, that will be the better option. So let's see the all the study and their quality of evidence. So among the pyramids, so the meta-analysis is the best study among the all studies. So from descending order, like meta-analysis is the best. Then second best could be the systematic review. Just don't confuse between the like expert opinion or the case report. It is a systematic reviews are better. Then next is a randomized control trial, and these are the experimental studies or the then the now analytical studies like cohort study is better than case control study. Then other studies like case series, case report, ecological studies, and the cross-sectional studies. And last would be the expert opinion or the background information. So the correct option for this question would be the randomized control trial. So let's see the next question, or how will we give the preferences or the preferences of the epidemiological studies for the establishing a causality between the risk factor and the disease. So first preference will be meta-analysis. Then if there is an option of systematic review, then randomized control type. Then other studies like analytical studies like cohort study, case control study, then cross-sectional, then ecological study. Among the cohort studies, if there was options like retrospective cohort, prospective cohort, and the mixed cohort, then among the cohort study, mixed cohort would be the better than retrospective cohort. No, a mixed cohort would be the better than prospective cohort. Then last one will be the retrospective cohort. So mixed cohort will be the better option among the cohort study. So let's see the another question. So this was the question between the for the coefficient of correlation. So the question was like coefficient of correlation between the variable A and B is a -1, and what will be the relation between the the data A and the data B. So the options were like there is a A increases, then B decreases. Option B is like A increases, then B decreases, like that. And C is a both remain same, then no correlations. This was the options. So what is the coefficient of correlation? So coefficient of correlation is a relationship between the two quantitative variables. It is represented by the scatter diagram, and it is the coefficient of correlation. It is denoted by the small letter r, and it is lie between the -1 to +1. So let's see, like we have to see just three graphs. Like imagine this is the graph. So this would be the A and this would be the B. Another graph with the relation between A and B. Is consider like this option. A straight line from the midline. From the given chart, we can see that when the B is increasing, A is also increasing for a particular time. So this could be the positive, a perfect positive correlation between the variable A and B. And another graph like this. In this chart, when the B is increasing, A is falling, like that. And the B is here, A is decreasing. When the B is increasing, A is decreasing. So this is a perfect negative correlation between the variable, like A and B are inversely proportional to each other, and in this chart A and B are directly proportional to each other, like A is increasing, directly the B is increasing, and in between this the coefficient of relation lies like from -1 to +1. And if the coefficient of correlation is 0, if R is equal to 0, then the line could be like this. So there could be no relations between the A and B. Like, let's see the different scatter diagrams for the coefficient of correlation. So coefficient of correlation is demonstrated by the scatter diagram. So scatter diagram is like we have already seen in the first diagram which we have drawn. So perfect one is like perfect positive. The coefficient of A and coefficient of B are directly proportional to each other. And the perfect negative is this, like a -1. So A and B are inversely proportional to each other. And A increases, B decreases. And in between this, if there is a correlation, coefficient of correlation is 0, then would be the random relations. There is a no correlations between the A and B. And among between 0 to +1, there would be the positive correlation, and between the -1 to 0 would be the negative correlation. So if the coefficient of correlations is between the 0.8 to 1, it is considered as a very high correlations. So the coefficient of correlation must be above 0.7 to make it as a proper or a high correlations between the two variable A and B. So this would be the so let's see the questions. So coefficient of correlation is -1. So they have given the -1 like these diagram. So A as the B or as the A increases, B decreases. So in this question, the option could be B option. A increases and the B decreases. The relations between the two variables would be the negative, that is inversely proportional. So let's move towards the next question. This was the easy. Which of the following is a measure of a central tendency? So we know that the measure of central tendency would be the just mean, median, and mode. So among the options, the only confusing option is the standard deviation. So it is standard deviation is not the measure of a central tendency. Standard deviation is just a deviation from the mean. So let's see the measures of the central tendency. So the measures of central tendencies are mean, median, and mode. And we how know that how to calculate the mean. Mean is calculated by sum of the all the values divided by the total number of the values. So it is like sum of the all the values divided by the total numbers. And median is a middle value of the data when the observation or data is properly sorted, like ascending to descending or in some particular order. If the data would be a odd number, then it will be the easy. But if there the data will be the even number, like 1 to 10, so then 5 and 6 would be the middle values, and among the we have to take average of that, like 5.5 would be the best option for the median. And mode is a most common or most frequently occurred value, and it can be a bimodal, trimodal, or multimodal also. So let's see the important aspect of the mean. So mean is a calculated by sum of the all the values divided by total number of values. An important point regarding the mean is that it is also known as a arithmetic average. And the mean is so important for important about the mean is that it includes all the values. So it is most affected by the extreme values or outliers. Like if the data was 1 to 10, and the last value would be the 50 or 60. So the among the after the calculations of the these data, the mean of the given data would be like after adding this 60 would be more affected because of the high value in the high value of the last data, like outliner or the extreme value. So mean is mostly affected when there is a presence of a extreme values. So in that case, we can use the we cannot use a mean as a central tendency. In that case, we can use a median or mode. Median or mode, because median and modes are not affected by the extreme values or the outliners. So let's see the median. How we calculate the median? Just the middle values of the data when it's arranged in a ascending or a descending order. So the median is like, yes, 50% data would be the on the right side of the median, and 50% data would be the on the left side of the median. And most important point regarding the median is that the median value, it is not affected or not impacted by the outliners. So if there is a skewed distribution of the data, we will see in the standard deviation. If the data is having extreme values, it will not affect the median. So median would be the better central tendency in that case. So modes, it is easy. Modes is the most frequently occurred data. Mode is also not affected by the outliners unless the outliner is the most common value. So mode can be a unimodal, bimodal, or trimodal, or a multimodal also. So let's see the what is the standard deviation. Standard deviation is a deviation of the particular values from the central values, like from the mean. So let's see the standard deviation. So the standard deviation would give the normal distribution curves like that. So the how we among the between these two normal distribution curve, what is the difference? The difference is that this curve has a high standard deviation. So high standard presence of a high standard deviation means the data is more dispersed, or the values are more wide range, or it has a wide range or from the central values. And from this data, it indicates the standard deviation is low. That is, there is a low dispersion of the data. So let's see this slide. In this in first curve, there is a low deviation. That is, there is a low standard deviation is indicated of the data, so that the graph or the normal distribution could be the like a steeper. And if the standard deviation of the data would be the high, the curve will be the more wide, and it indicates the greater variability in the database, or it indicates the more dispersion of the data. And the normal distribution, so the normal distributive data indicates the yes, this is the mean of the curve, and among the one standard deviation, like mean plus minus one standard deviation, it includes near about 68% of the data. Mean plus minus two standard deviation, it includes near about 95% of the data, and mean plus minus three standard deviation gives about the 99% of the data. And in the obesity we have seen that sorry, in obesity we have seen that the for the pediatric patient, obesity or the severe obesity is considered when the weight of the baby is more than 95 percentile. So it would be the, if the obesity in pediatric patient could be the more than 2 standard deviation of the weight of the particular pediatric populations. So this would be the useful in that case. So then the data could be the normal distributive data, or it could be the skewed data like outliners. So if the outliner is there, the data could be the right skewed distribution, or could be the left skewed distribution. In that case, we have already seen that if there is a skewed distribution, in that case, the best measure of central tendency would be the median, because the median is not generally affected by the skew distributions. So and the values are changes, like in case of a right skewed distribution. So there is a skewed of the data on the right side. So this is a right skewed distribution. In that case, the values like mean is more affected by the outliners. So mean would be the bit more than median, then mode. So mode is a least value. In that case, in the standard normal distribution, the mean is equal to median equal to mode. And right skewed distribution, the mean is more than the median is more than the mode. And similarly for the left skewed distribution, mode is more than median than the mean. So the mean is least commonly affected because of the skewed distribution of the data. So mean would be the median would be the better useful central tendency among the skewed data or the presence of the outliners. So let's see the in normal distribution, mean is equal to median is equal to mode. In right or a positive skew distribution, mean is more than the median and the mode. And left skew distribution, mode is more than the median than the mean. And for the most, let's see, the most affected measure of central tendency because of the extreme value or outliner is a mean, and least affected measure of central tendency would be the mode. And but for the most preferable measure of central tendency is median. So if the data or given is having a normal distribution, mean is best. But if there is a right skewed or left skewed distribution, median would be better than mode. So let's see the another next question. So this is the question from the topic anesthesia, general local anesthesia and the general anesthesia. In that, the question was, which among the following local anesthetic agent with the 8 hours of action in a carpal tunnel release procedure is used? Like among the following, which has the highest mechanism of actions to be used in a carpal tunnel release? Like this was the direct from the chart given in the substance. So this was the different local anesthetic, and this the duration of action was given, like for the lignocaine and mepivacaine, it is about 60 to 180 minutes, like near about 3 hours. And for bupivacaine and ropivacaine, the duration of action could be near about 180 to 160 minutes, near about 6 hours. So among the options given, the better option could be the bupivacaine. So we all already know that we the bupivacaine has a longer duration of action, so that we can do a longer procedure, or we can combine the lignocaine and bupivacaine for the local during the local anesthesia, so that we can increase the duration of action. So this was the easy question. So among the next question would be the drug which act on the both HER2 new and the EGFR associated tyrosine kinase. So this was the question, could be the overlap between the endocrine as well as in the general surgery. I have taken this question because of the question was directly from the table given in the 12th chapter from the general surgery, like principles of the oncology. So they are asking about the dual inhibitors of the tyrosine kinase. So which one is the dual inhibitor? So let's see the chart given in the Bailey. So there are different tyrosine kinase inhibitors mentioned in the this chart. We just see the important tyrosine kinase inhibitor we can that can be useful in the general surgery or surgery. Like first is a imatinib. So imatinib is it inhibits the mutation, or it is a c-KIT inhibitor. All are the tyrosine kinase receptor blocker. So among that, it has a imatinib. It inhibits the c-KIT. It is a c-KIT inhibitor useful in the GIST. And another drug would be the sunitinib, regorafenib, and a levonatinib. These all are the inhibitors of the PDGFR, VEGFR, KIT, and FLT. So, in case of a GIST resistant to the imatinib, we can use a sunitinib, regorafenib, and the levonatinib. So, these drugs can be useful in renal cancers, GIST refractory to the imatinib, colorectal cancers, or thyroid cancers. And another important regarding the imatinib is that the imatinib, if the gist is having exon 11 mutation, it gives best response to imatinib. And if the gist has a mutation in 9 codon, then it is a resistant to the imatinib, or it could be the wild type of gist, which is wild type is like c-KIT negative and the PDGFR negative gist. In that case, the imatinib would be the not useful, or we have to provide a double the dose of the imatinib, or we can give the sunitinib or a regorafenib in that case. So just remember, exon 11 is a good for the response to the imatinib, and exon 9 mutation is a resistant to the imatinib. Another drugs are tyrosine kinase inhibitor is a lapatinib. So lapatinib, it inhibits the tyrosine kinase associated with the EGFR and the HER2. So it is a dual tyrosine kinase inhibitor, which inhibit the EGFR as well as the HER2, which is useful in the breast cancers. And axitinib, it inhibits the tyrosine kinase associated VEGFR, which is useful in the renal cancer. So let's come back to the questions. So the dual tyrosine kinase inhibitor would be the lapatinib. So this would be the answer for this question. So let's see another easy questions from the general surgery. Like all are the components of the DCR, like damage control resuscitation. So this question would be, we have already discussed in one of the test and discussion of the Levin Bailey. So the options are correction of the acidosis, avoid hypothermia, anticipate the coagulation, acute coagulopathy, and the treat it and maintain the MAP more than 90 mmHg. So let's see the basic principles among the what are the key basic principles of the damage control resuscitation. So it includes the rapid hemorrhage control, permissive hypotension, avoidance of the dilutional coagulopathy, and treatment of the existent coagulopathy. So in case of a rapid hemorrhage control, we just control the bleeding as possible, and if there is a very high bleeding, or if the patient may need a damage control surgery, then we can just do the arrest of the hemorrhage, control of the sepsis, and the protect from the future further injury, or we can proceed with the damage control surgery. The another component is a permissive hypotension. So permissive hypotension is maintained till the control of the hemorrhage. So if we give a wide amount of fluid, or then fluid overload can be happen, and it will causes increase in the bleeding, and it may also causes the dilutional coagulopathy, which ultimately increases the bleeding, and it also increases the hypothermia, and this will lead to the triad of death, like acidosis, coagulopathy, and the hypothermia, and may cause the death of a patient. So till the control of the hemorrhage, the target BP should be around, mean arterial pressure should be around 50 mmHg and not the 90 mmHg. So, and the last one is the treatment of the coagulopathy. Like we can give a tranexamic acid, cryoprecipitate, platelets, and the FFP to treat the coagulopathy. And if we necessary, if a blood or a massive transfusion protocol is started, then we can provide the PRC, FFP, and platelet in the ratio of 1:1:1, so that to avoid the coagulopathy. So this was the direct line from the Bailey. So it has mentioned that for the permissive hypertension, the mean arterial pressure above 50 mmHg, near about the 50 mmHg, must be maintained by whatever means, not the 90. So the among the options, the exception would be the maintain the MAP more than 90 mmHg. So this was the easy one. So let's see the basic criteria for the damage control surgery and the early total care. Just remember the criteria of the damage control surgery. So the deadly triad like hypothermia, acidosis, and coagulopathy. Hypothermia is temperature less than 34. Acidosis is pH less than 7.2. Serum lactate like acidosis can be measured by pH as well as serum lactate more than 5. Serum lactate more than 5. Coagulopathy in the form of PT ratio or INR, PT INR, blood pressure less than 70 mmHg, transfusion approaching more than 50 units, and injury severity score more than 36. So injury severity score more than 15 is a definition of a major trauma, and injury severity score more than 36 is an indication for a damage control surgery. And among the coagulopathy, when the APPT, PT more than 60, more than 16 second could be the indication for the damage control surgery, and APTT more than 60 second could be the indications of the damage control surgery. So these are the criteria for the damage control surgery. So let's see the another question. Questions from the biostat again. So a population is divided into the 5 groups, and then the peoples were randomly selected from the each group. What is the type of sampling method used in this study? So let's see the different types of the sampling method used in the epidemiological study or for the selections of the peoples from the populations, or selection of the samples from the population. So let's see the different methods. So first is a first would be the method of sampling would be the simple random sampling. In the simple random sampling method, there is a every element in the population has the equal chance to being included. Like problem in screen sharing. So let's see the simple random sampling. So in the simple random sampling, every element in the population has equal chances to being included. Let's see this image. From this image, we can get the concept of simple random sampling. So this would be the population of population including peoples, and among the populations or among the all the groups, the peoples or 4 samples are selected randomly. There is a no distribution of the or the division of the populations, just randomly selecting. Like we do the lotteries in the lottery settings. So this is like a lottery setting, simple random sampling. Every element in the population has equal chances of being included. There is a no systematic method applied for the selection of the sample. Just randomly among the group of or a class of 100 students, just randomly we selected the 10 students for the study. There is a no any applications of the distributive sampling or the systematic distribution of the group. This just randomly selecting the all from the all the group. Let's see another method. Another method is a stratified random sampling. In this method, first the population which we have to study is the population is initially divided into the homogeneous group of strata. Like among the class of the 100 student, the students are divided like boys, one group of boys and another group of girls are divided, and from that each group the three people from the boys group and three people from the girls group are randomly selected. So initially the whole population is converted into or divided into the different stratas, and from each strata the population or the samples are taken. So this was the demonstrated in this chart. Like we have divided these population into the three different strata. So this one would be the first strata, this was the another strata, and this is the third strata. So 1, 2, 3. So we have population is divided into three homogeneous group or strata, and from each strata the samples are selected randomly like this. So initially the population is divided into the homogeneous strata, and from each strata the samples are randomly selected. So let's see the another method. The another method is a clustered sampling. Just don't confuse between the clustered sampling and the stratified random sampling. The cluster sampling is like, just we will give the examples of populations. So just see, consider India is a population we have to study. From the India, there are 28 states. From the states, there is another multiple clusters of district from or another multiple states from, consider that Maharashtra. It is like a multi-stage sampling method, and from the Maharashtra there are multiple districts like Pune, Mumbai, Nagpur. These are the multiple, this could be the multi-stage sampling. So among these are the clusters, like the single district could be the cluster for the study of the population. So if consider the examples of study of the vaccination, it is adequately giving the response or not. So we cannot study whole the Indian population. So among the different state, we select the different district, and from the whole district is studied. Like from the Maharashtra, one district is selected, from another state, from the AP one district is selected, and like that. So the clusters are the district, and from the for the sampling, the whole cluster is considered as a sample. So let's see the this slide. So if these are the clusters, so the population is divided into the different clusters. This is the cluster, this one is the cluster, this one is the cluster, this is the cluster, like that. This population is converted into the 6 clusters, and the sample are taken are the not the individuals from the cluster. It is the direct clustered is considered as a sample, like that. This whole clustered is considered or taken as a sample, and same for that. So the two clusters among the populations are considered or taken as a sample. In stratified sampling, in case of a stratified sampling, we just take the individuals from the each strata, not the whole strata. So this is the basic difference between the stratified random sampling and the clustered random sampling. In the cluster random sampling, we directly take a clustered as a sample, and stratified random sampling, we take an individual from that strata. So last one method is simple systematic random sampling. The compare the first um, examples like simple random sampling. In the sample random sampling, we take a 10 student from the class of a 100 student, and there is a no proper sampling method is applied. So in systematic random sampling, there is a systematic pattern for a selection of the element of a sample. Like that, among the, if the class, it is a class of a 100, it is like a 100 student. First sample is selected randomly. Sample is selected randomly, and then every third or every 10th student is selected. Like if this could be the roll number of the patient, the roll number 2 is selected, then every third roll number is taken. Every third roll number is taken. So this is the systematic random sampling, and this was the simple random sampling. In simple random sampling, there is a no proper system is applied for the taking the sample, and in the systematic random sampling, there is a systematic pattern to selecting the element of the sample. Like every third or every 10th is selected, every fifth is selected, like that. So from let's see the question. So population is divided into 5 groups. So these 5 groups are the stratas. So these are the stratas. So among, and the peoples were randomly selected from the each group. So they have clearly mentioned the peoples are randomly selected from the each group. So population is converted into 5 homogeneous group, and then peoples are selected randomly from the each group. So this could be the stratified sampling. And why not the clustered sampling? Because all the group is not selected as a sample. So among the 5 groups, if the directly 2 groups are selected for the sampling, so that could be the clustered sampling. So the question has mentioned that peoples were randomly selected from each group, not the whole group. So the answer, the correct option for this question would be the stratified sampling. So let's see the next question. Next question was, which of the following is true for the keloid? And this would be the easy question. So in the keloid, there is a, so the keloids and the hypertrophic scar. Keloid versus hypertrophic scar. Hypertrophic scar, the keloids in both, there is an increase in the collagen. So there is an increase in the collagen synthesis, but the arrangement is different. Depending upon the arrangement, they are classified. Like if the arrangement is parallel arrangement of the collagen, then it is a hypertrophic scar. Hypertrophic scar. If the arrangement is if haphazard or a random arrangement, then it is a keloid. So this could be the high collagen with randomly arranged. This could be the correct option for this question. And this was directly given in the Bailey, like the abnormal scar, these abnormal scars contains the excess collagen. So there is a high collagen, which if arranged in a disorganized pattern in keloid scar. So keloid has a disorganized pattern of the collagen and parallel pattern in the hypertrophic scar. So the correct option would be the option C for this question. And let's see the basic chart given in the Schwartz for the comparison between the keloid and the hypertrophic scar. The important point regarding it's the keloids. We note that keloid crosses the edges and the hypertrophic scar does not crosses the edges. Keloid has a genetic predominance, like it has an autosomal dominance with a incomplete. It has an autosomal dominance with incomplete penetration, and there is a no such genetic predisposition for the hypertrophic scar. And the contractures are more frequent with the hypertrophy scar rarely with the keloid, and the spontaneous regression is possible with the hypertrophy scar, and the keloids once developed they do not spontaneously regress. And the common sites of for the formation of keloids are neck, chest, ear lobes, shoulders, upper back. And hypertrophic scar can be anywhere, like mostly in the tension line, tension, suture tension lines. And the histologically, let's see that histologically difference between the keloid. It is a thick wavy collagen fibers arranged in a random orientation, and for the hypertrophy scar there is a parallel orientation of the collagen fiber. So this was the easy. The high collagen and the randomly arranged collagen is for the keloid, and high collagen and parallelly arranged collagen would be the hypertrophic scar. So let's see the last question. This was also from the biostat. So the bias, various different biases can be asked sometime. Let's see the question. The bias occurred due to the different hospital admission rates. So let's see the various types of basic biases which can be repeatedly asked, or can be the potential questions for the upcoming NEET. So the various different biases in the epidemiological studies are like observational biases. Like there is a differential ability to observe. It is a subjective bias. Like the observer is biased, and he is observing differently for the cases and differently for the control group. So and that could be the avoided by the blinding procedures or blinding. So that the observer is not knowing the whose are the cases and which group is the cases and which group is the control group. So that could be the blinding, like triple or a double blinding. Interviewer bias, like interviewer is asking leading question to the subject and interviewing the cases thoroughly than the controls. So interviewer is know that which are the cases and which are the control group. Like in case of a randomized control trial, the interviewer is already knowing the which group is taking the new drug and which group is taking the older drug, and he is asking the leading questions to the cases group or the population under the experimental group. So that could be the interviewer bias, and this could also be eliminated by the blinding, so that interviewer could not know that which group is a experimental group and which group is a non-experimental group. Recall bias. Recall bias in case of a cases control study, we ask the questions to the cases or the non-cases people and see the history or take the history. And in that case, there could be the recall bias. So it is a differential ability of the cases and control to recall a certain detail, like the duration of the smoking, or the what is the amount of alcohol he is taking in the last 10 or 15 years back. Notification bias or a reporting bias. So these are like deceased associated with the stigma are reported less, like tuberculosis or polio. Like in that case, the notified diseases are not reported correctly. Like during the COVID cases, many states are not reporting the actual number of the positive cases and the death occurred due to the positive cases. Like the same what happened in this recently in the Kumbh Mela, like stampede has happened, and the media or the authorities are not giving the correct data of what is the amount of death that occurred due to the stampede. So these are the notification bias or the reporting bias. Another example is a Bergsonian bias. Bergsonian is biased due to it is affected in the hospital-based case control study. It is due to the differential hospital admission rate. So the question could be the bias due to different hospital admission. The answer for this question could be the Bergsonian biases. Let's see the another examples or potential questions from the bias, like selection bias. Selection bias is a sampling bias. It is a sampling bias. It is also by the interviewer or the populations are non-randomly allocated, like non-random allocation of the subject that do not represent the actual population. Like we have to study the role of smokers and non-smoker, and the selection could be the between the smoker and non-smoker. And if the selection could be the false, like the people's from the non-smoker or the in cases sometimes the particular area is sometimes would be the population with full of smoker. In that case also the population will have a higher risk factors, and there is a less population for the non-risk factors. So that could be the selection bias. So it could be the eliminated by matching, like the cases and the control should have the proper there should be the same geographical region, same other risk factors, if the smoker is there, and if there is a intake of alcohol also there, that could be the confounding factors. So that could be the eliminated by the matching. So the selection bias. The another bias is a Hawthorne bias. Hawthorne bias is due to the change in the attitude or action of the subject under observation. Like in case of a randomized control trial, if there is an experimental group and there is a non-experimental group, and we are giving the experimental group a particular new drug, and we are giving a non-experimental group, there is a no drug is given. The experimental group or the non-experimental group population will, after knowing that the new drug is not giving to them, they will take or change their attitude and taken the or shift from non-experimental group to the experimental group and taken or started taking the new drug, or vice versa can be happen, like experimental group is not taking the drug at all, so that they have changed the attitude. So or they change the action under the observation. So this is due to the Hawthorne bias. So this could be the eliminated by adding the like a if the experimental group is experimental for some particular drug, the placebo drug can be given to the non-experimental group also, so that they can not know that the experimental group is having different treatment and non-experimental group is treated differently. So this could be eliminated by adding placebo, or would be the single blinding, like the experimental groups and non-experimental groups would not know the exact drugs on which they are. So the another factor is confounding bias. Confounding bias is like factor which is related to both exposure and the outcome. Like smoking causes lung cancer, and mostly the smokers are also take the alcohols, or alcohols can be the smoker. So alcohol could be the confounding factor, because alcohol can affect the risk factor also, and alcohol can be risk factor for separate risk factor, independent risk factor for the formation of the lung cancer. So alcohol could be the confounding factor, and this could change the result. Like the smokers are also taking alcohol, and non-smoker are generally if they are non-alcoholic. So the combination effect of smoking as well as the alcohol, it will increases the risk among the experimental or study group to produce the lung cancer. And the non-experimental group would be the because of these are non-smoker as well as non-alcoholic, there could be the best chances of getting low incidence of the lung cancer among the non-exposed group. So that the exposure or the non-exposures are biased due to the confounding factor like alcohol. So this could be the eliminated by matching. So the matching, proper matching would eliminate this factor. Last one is the attrition bias. Attrition is bias is due to a participant is lost to follow. So initially we have study group of 100, and finally after the some years the study group would be just remain 70, and after some another 5 years the study group would be remain only 50. So from that there is a loss to follow up multiple subject. So it will affect the final results of the study. So this could be the due to attrition bias. So this is the complete general surgery and more of biostat questions from the previous year NEET 2023 NEET SS. So the next session would be the for the CVTS, and thank you so much uh, and all the best for examination. So the next session would be start from the so the question was, which type of bias is not removed by blinding? So blinding, like so blinding is basically for the, just see the example. So blinding is basically for the observational bias, interviewer bias, and for the selection and for the Hawthorne bias. So like in a single blinding, the experimental subjects are not knowing that there are under observation, or they are having getting particular term. Double blinding is like the experimental subject as well as the interviewer is not knowing the what are the cases and what are the control. And triple binding is like subject as well as the interviewer as well as the study observer. These three people are not knowing the what is going under the study. So triple binding would be the best blinding, and the blinding generally eliminates the observer biases, interviewer biases, and the Hawthorne biases, and other biases cannot be removed by matching proper blinding. Though particular may I have already mentioned which biases can be removed by particular some biases can be removed by matching, or some biases can be removed by the randomization, like selection bias can be removed by the proper randomization technique, so that the non-random allocation of the subject could be the eliminated. So just this is all about the this session. Thank you so much and all the best for your examination. The Dr. Isaki sir will start the next session. Thank you. Rajan sir, you can start your session.
So, yeah. So, hello everybody. So now we will be seeing about cardiovascular and thoracic surgery previous year questions. Now we are all after a hectic session of general surgery here. Of course, being a general surgery resident is really a tough one, because after a long day, after completing a long day, by 9 or 10 o'clock, we'll be having our dinner, followed by very interesting movies for relaxing. So this session is going to be a very interesting, very important session, followed by a session which is going to make a difference in marks. So let's go into the session. The first question here is the most common electrolyte abnormality caused by a paraneoplastic syndrome in bronchogenic carcinoma. So this question is from CA lung. So the answer here will be hyperkalemia. So for answering this question, we should know about the paraneoplastic syndrome and the bronchogenic carcinoma. So what is paraneoplastic syndrome? Paraneoplastic syndrome is nothing but it is a result of organ or a tissue damage at a site other than the site of a primary tumor. That is the definition of paraneoplastic syndrome. Paraneoplastic syndrome is nothing but it is the result of organ or tissue damage at a site other than the site of a primary tumor. Okay. So what will be the clinical features of paraneoplastic syndrome? So the paraneoplastic syndrome is commonly associated with lung cancer, preferably the paraneoplastic syndrome that is associated with the primary lung cancer can cause either a neurological symptoms or endocrine dysfunction, even a dermatological dysfunction, rheumatological dysfunction, hematology, and ophthalmic dysfunction, lung cancer, and this is called as paraneoplastic syndromes. And the common metabolic or electrolyte abnormality that is caused in bronchogenic carcinoma is humoral hypercalcemia. It is humoral hypercalcemia. So, and the other things are SAADHs. So, the answer for that first thing will be hypercalcemia. So, coming to the second question, you'll be going with the clinical-based discussions, and the clinical-based questions are most commonly asked one. A 20 years old male patient presenting to an emergency room with a history of penetrating injury to the left lower chest. In patient's word, on clinical examination, patient has hypotension, muffled heart sound, and elevated JVP. How will you proceed with this case if you are the primary physician, treating patient there? So, with the clinical points of hypotension, muffled heart sound, and elevated JVP. So, this constitutes the Beck's triad. So, this is the feature of cardiac tamponade. And the point of penetrating injury to the left lower chest. So, anatomically, we can point out the area of heart. So, from this history, we can come to a diagnosis of cardiac tamponade, which is, of course, an emergency situation to be tackled earlier. So, always coming to the management part, we have to discuss about the investigation. And EFAST is the commonly done bedside non-invasive test to diagnose the pericardial collection, and we can go for an emergency needle pericardiocentesis. So the answer for this question will be option A, EFAST and needle pericardiocentesis. So what is EFAST is? How it is being done? What are the sites that are marked? Sites that are seen in EFAST. this is an important point which we are supposed to know for answering the MCQ questions. Okay, so after doing an EFAST, an ultrasound to find any free fluid in abdomen or any free fluid in the lung, that is thoracic cavity, and pericardial collection, we are going for a emergency needle thoracotomy. So how to do this can be done as a image guided pericardiocentesis. Of course, patient in a supine position, after infiltrating local anesthesia to the skin, we can use a 20 or a 22 gauge needle. After infiltrating the local anesthesia, in a supine position, in the subxiphoid area. The needle to be angulated to the skin at 40 to 45 degree. The angle between the needle and the skin should be 40 to 45 degree in the subxiphoid area, and the needle pointing towards the left shoulder is the direction of insertion of the needle. So after inserting, you can go for an aspiration. This is called as emergency pericardiocentesis done in case of cardiac tamponade. So coming to the third question, a 35 years old male presented to the emergency room with alleged history of stab injury to the neck. So stab injury also comes under a penetrating neck injury. Penetrating injury to the neck. On further evaluation, patient was suspected to have a 2 centimeter rent in the common carotid artery. Of course, patient will bleed heavily. So what will be the definitive management? The point to be noted here is in the question is the definitive management after arresting the bleeding. So what the questioner expects from us is that we should give the definitive management for the rent in the common carotid artery after arresting the bleeding. So this is the question here. In this clinical scenario, of course, my first step is the arresting the bleeding somehow. So here the definitive management is that you can go for a common carotid artery bypass grafting. You can go for a common carotid artery bypass grafting can be done. So what can be the other appropriate answer is that you can go for an answer if there is an answer of common carotid artery repair followed by an anticoagulation therapy. We can go for this answer. As this question doesn't have this answer, they're going for a common carotid artery bypass. So what is the carotid artery endarterectomy means? In case of any atherosclerotic lesions, in case of any atherosclerotic lesion, in carotid artery causing significant narrowing, and of course patient is symptomatic with the TIA, that is transient ischemic attacks. Then the treatment option will be carotid endarterectomy, that is, we will open the carotid artery and we will remove the plaque inside it, followed by resuturing and repair of the carotid artery with anticoagulation therapy. So this is carotid endarterectomy. You should also know about the carotid endarterectomy from this question. And this session not only aims for discussing the question, but also for giving you various points which you are supposed to know about for exam purpose and also for practical aspects. So the carotid endarterectomy is the procedure that is done for treating the atherosclerotic lesion that is causing significant luminal narrowing in the carotid artery. And also the patient should have a clinical symptoms of TIA, that is transient ischemic attack. We can go for carotid end arterectomy, which means that the carotid artery will be opened and atheromatous plaques are removed, followed by repair, followed by an anticoagulation therapy. Of course, any vessel, any major vessel, if opened, this should be opened and closed with or repairs done. You should preferably go with the anticoagulation therapy for sure. So the answer for this above scenario will be a common carotid artery bypass. If you have an option of common carotid artery repair followed by an anticoagulation therapy, you can go for this. Of course, common carotid artery bypass also needs a follow-up with the anticoagulation therapy, either with the warfarin or azithromycin. And the parameter for monitoring the anticoagulation therapy is INR, International Normalized Ratio. So coming to the next question. So we are getting lots of questions from drama, chest drama. So this signifies the importance of reading the chest drama and ATLS, Advanced Trauma Life Supporting. So the fourth question will be, in case of a patient with a chest injury with a sucking wound, how will you treat this patient? If a patient presents with a chest injury with a sucking wound, of course, this is also a open injury, maybe due to a penetrating chest injury. How will you manage this case? Option A, either we will go for an emergency thoracoplasty with ICD incision or an emergency sternotomy and proceed to find the any other pathologies inside, or you will go for a 3-way flap cover closure followed by an ICD insertion, or you will just close the wound by suturing with a non-observable suture material. So what will be the answer here? So the correct answer will be 3-way closure with the ICD insertion will be the correct answer here. So 3-way closure, flap closure with the ICD insertion is the answer here. Of course, here I would like to tell about a point from general medicine, general surgery topic. Should all know about the homeostasis. That is an equilibrium that is maintained inside the body. Of course, there are several buffer system to correct the damages caused, and this will be like a closed loop. Injury will be corrected by the body itself. When this closed loop becomes an open loop, the damage is more severe than the body can correct itself. We should go for an intervention. Of course, initially we should go for a minimally invasive intervention, that is a minimal damage control procedure. So preferably we can go for a 3-way flap cover with ICD insertion for chest injury with the sucking wound. So what is the pathogenesis behind the sucking wound? So you can see during the inspiration, lung inflates and during the inspiration, so we'll start with an okay. During the inspiration, what happens is that inside the thoracic cavity, lung gets inflated and the pressure increases inside the thoracic cavity. And during the expiration, lung deflates and there will be a negative pressure inside the thoracic cavity. So this is the normal physiology that happens inside the thorax. So if you have an open wound here, resulting in communication between the thoracic cavity and the atmosphere. During expiration, when deflates, because of the negative pressure, the air will be sucked in. Air will be sucked in. As you can see in this diagram, the air will be sucked inside the thoracic cavity, and this air will get filled up, resulting in pneumothorax, causing compression of the lung, resulting in the collapsing of lung. So lung cannot expand. This trapped air inside the thoracic cavity during inspiration, even when the lung gets inflated, this cannot go outside easily. The air that gets collected in the other parts will remain as it is, causing increased intrathoracic pressure. This results in the poor inflation of the lung during inspiration. So this happens. This is the pathophysiology behind the pneumothorax in open chest injury. So this is called as tension pneumothorax. This results in further increase in the intrathoracic pressure. This results in the further increase in the intrathoracic pressure, resulting in complete collapse of the lung. And also this has compression effect over the heart, resulting in hypotension. And of course, we can see a mediastinal shift in these cases, in severe cases. So, is it necessary to know all these points? Yes, of course. That can be a clinical scenario where we should know all these points. The mediastinal shift can also be due to the tension pneumothorax or a massive pneumothorax. And the BP will fall in pneumothorax, in tension pneumothorax. So these are all points which we are supposed to know to attend a clinical scenario-based question. Okay. So coming to the treatment aspect. You know about the treatment aspect, this is like a three-way valve. How to make this three-way valve and how this act. So in this image, we can see a plaster placed on the three sides. It is completely occluded. Occlusive tapes are placed in three sides, and one area is being left unocclusive, not occluded. So during the inspiration, when the lung expands, during the inspiration, when the lung inflates, the intrathoracic pressure will be high. This will push the air outside. And the air will escape through the unoccluded area. This is how the lung can expand. During expiration, the intrathoracic pressure will reduce. And it will suck the air from the atmosphere. When there is an three-way occlusive dressing applied, the air cannot enter into the thoracic cavity. So this is the mechanism behind the three-way occlusive dressing for open chest sucking injury. So coming to the next question of first question, in a case of tension pneumothorax, what is the site of needle thoracostomy? Of course, needle thoracostomy is an emergency procedure. And what will be the site of insertion of needle? Preferably, nowadays, in clinical practice, we will be going for an emergency ICD insertion for these cases. In clinical practice, we will be going for an emergency ICD insertion for the patient with tension pneumothorax. So here the question is, what is the site of needle thoracostomy as per ATLS, Advanced Trauma Life Support System Protocol? So here the answer will be second intercostal space in the mid-clavicular line. So this question can also be asked as in case of an child or an adult. Okay. So what is needle thoracocentesis? Of course, it is an emergency procedure. So we should know about 3 points here. Okay. First is that what is the size of the needle used in needle thoracocentesis? This can be another question. So the size of the needle that is used for needle thoracocentesis is 20 to 22 gauge needle. So the size of the needle that is used for needle thoracocentesis is 20 to 22 gauge needle, and the site of insertion of the needle can be marked by you can see in this diagram. So you should know about the anatomical landmark of angle of Lewis. Angle of Lewis is at the junction of manubrium sternae and the body of sternum. The sternum can be divided into 3 parts. That is a manubrium sternae, body of sternum, and xiphoid process. So the junction of manubrium sternae and the body of sternum marks the angle of Lewis. And the horizontal line drawn along the angle of Lewis and the vertical line or transverse line in the mid-clavicular line, the mid-clavicular point, and the site or point of intersection of these 2 lines is the site of insertion of needle for needle thoracocentesis. This will be in the second intercostal space. This will be in the second intercostal space. So the intersection point of a horizontal line drawn along the angle of Lewis and the transverse line in the mid-clavicular line. The mid-clavicular line is the site of insertion for needle thoracocentesis. And of course, while reading this question, we should also know about the anatomy. So the site of insertion is more important. The needle should be inserted at the upper border of the lower rib. Okay, needle should be inserted in the upper border of lower rib. Why? So in the intercostal spaces, we can have a intercostal vessels, an intercostal nerve, intercostal neurovascular bundle running along the lower border of the ribs. Of course, the upper border also contains accessory intercostal vessels. Accessory intercostal vessel will be present in the upper border of the rib, while the main intercostal vessels and nerve will be present in the lower border of the rib. So site of insertion will be in the upper border of the lower rib in the intercostal space. Going for a second intercostal space, you have to place and insert a needle at the site of upper border of the lower rib present in the second intercostal space. To know about the anatomy, of course, the skin, next will be the subcutaneous tissue, followed by the chest wall muscles. Chest wall muscles will be here. Then we'll have the rib and the intercostal muscles. We will have 3 intercostal muscles. And we will enter into the parietal pleura, pleural cavity, and visceral pleura here over the lung. So this is the pleural cavity. This pleural cavity is bounded by parietal pleura that is attached to the inner aspect of the thoracic cavity and the visceral pleura over the lung. So coming to the next question, it's a 6th question. So 6 years old male baby, a known case of ventricular septal defect. A known case of ventricular septal defect was coming to you with a echo finding of mild pulmonary hypertension, the cardiomegaly on radiological imaging. What will be your next step? How will you proceed? So here the point to be noted is that the baby is around 6 years. You can call it as a baby. It's a male child. It is a male child. known case of ventricular septal defect, patient had developed mild pulmonary hypertension with a cardiomegaly. In VSD, we should know the basic physiology in VSD. There will be a left to right shunting. There will be a left to right shunting of blood. So the blood volume in the right ventricle will increase, resulting in the increased blood flow into the pulmonary artery, which can further lead to pulmonary hypertension. So if we are closing this defect, what it will happen? The blood flow, the excess blood flow inside to the right ventricle will be stopped, and the blood flow will be more in the left part or left system of the heart to the systemic flow. So this cannot be done in all cases because cardiac remodeling would have been occurred. So before going for any corrective surgery, we should go for a cardiac catheterization study. So we should know about the parameters that has been studied in cardiac cath study. So first thing to be seen is the saturation or PO2. You can call it as a PO2 of the blood in different parts of the heart. We will catheterize the heart and we will take blood samples from different parts of the heart, like blood sample from the right atrium, and a blood sample from the right ventricle, and blood sample from the pulmonary artery, and one from the left ventricle, and we will check the PO2, that is partial pressure of oxygen. And of course, the catheter will have a pressure monitoring system at the tip, and the pressure inside the chambers and the main great arteries will be measured. So only based on these things, we will decide whether the case is operable or inoperable. So cath study, we will introduce the catheter through the peripheral approach, probably a radial artery approach, or through femoral artery or femoral vein. We will insert the catheter and we will reach the IVC from femoral. For example, we are catheterizing the femoral vein. We will reach into the IVC and then we will enter into the right atrium, and there we can take a sample of blood for arterial blood gas analysis or blood gas analysis, and we will measure the oxygen saturation in the blood in the right atrium, and then the catheter can be passed deep into the right ventricle, and from there we will take a sample, and the catheter can further be introduced into the pulmonary artery through the right ventricular outflow tract, and in the pulmonary artery the sample will be taken, and further we can even cross the septum through the VSD or an ASD, or by creating or piercing the septum into the left heart, and we will take a sample from the left heart, and this will be subjected to blood gas analysis for measuring the partial pressure of oxygen in the blood taken from the different part. And of course, the catheter will have a pressure monitoring system in the tip of the catheter, and the pressure in the different parts of the heart chambers, like right ventricle, right atrium, in the pulmonary artery, left ventricle pressure will be monitored, will be recorded. And only based on this, the congenital diseases can be decided whether it is an operable or an inoperable case. For example, to make it simple, if a 40 years male patient with an ASD, of course, ASD to be treated in 10 years, but most of the patient in the clinical practice come even at 40 years of age. So for those patients with ASD, there will be a left to right shunting, and the right atrium will get enlarged. Right atrium will get enlarged, and the more amount of blood will be passing through the. So I'll draw a diagram. So patient ASD. The question is VSD, but now we are discussing about an ASD. Because of ASD, there will be a flow of blood from the left heart to right heart. So because of this, the right heart will get enlarged. Because of the increased blood, the right heart will get enlarged. And in a due course of time, the blood flowing into the right ventricle will also increase, and into the pulmonary artery will also increase. And because of the increase in blood flow to the pulmonary artery, patient can develop pulmonary hypertension. When you are doing a surgery and you are occluding the ASD with a patch closure, maybe a pericardial patch closure or a synthetic patch closure, now the flow of blood from the left to right ventricle has been stopped completely. So the only source of blood for the right atrium will be IVC and SVC. But as the chamber has dilated, this will accommodate large amount of blood. So large amount of blood is required to get filling the right atrium. And after filling the right atrium, only the blood can enter into the right ventricle. So the volume of filling inside the right ventricle will reduce. The volume in the right ventricle will reduce. So of course, you all know about the Frank-Starling's law and law of Laplace. As the initial volume, that is preload of the right ventricle is less, the ejection fraction of the right ventricle, RVEF, will also reduce. This can result in right ventricular dysfunction, which is a difficult thing to treat. And the situation can even worse, and patient can even go for arrest or death. So before doing any congenital diseases, you are supposed to check whether this is a possible thing to make the patient alive for long time. So this is the basics of cardiac catheterization. So in this image, you can see the catheter being passed inside the heart, and the catheter is can be placed in the right atrium, and samples can be taken from the right atrium, or the catheter can be passed into the right ventricle for taking the samples from here, or this catheter even being directed into the pulmonary artery for taking the sample from here. This is how the catheterization can be done, and the pulmonary artery samples can be taken. And the catheter tip of the catheter can also have a pressure monitoring system. Can also have a pressure monitoring system to measure the pressure in the different part of the heart. So this is all about cardiac catheterization and its significance in clinical practice too. Okay, so cardiac surgery is more complicated one, but it's like a heroic one. So coming to the 7th question, a 72 years old male patient met with an RTA and had a chest injury. On evaluation, the patient has a multiple rib fractures with subcutaneous emphysema and a massive chemothorax. So what are all the indications for thoracotomy after ICD insertion? So from this, we can see that there's a rib fracture with a subcutaneous emphysema. So there may be an air leak and a lung injury may be present. So from this history, we can conclude that patient has a lung injury. It may be a lung contusion or a lung laceration. Preferably, it's a lung laceration because the patient has developed a subcutaneous emphysema and also patient has a hemothorax. So this is what we can conclude from the history. So what can be the indication for open thoracotomy and what are the situations which we should go for a thoracotomy? Two things. One is that massive air because of lung parenchymal injury. Second will be a massive hemothorax or bleeding inside the thoracic cavity resulting in hemodynamic instability. So these are two indications for thoracotomy. So here, of course, hemothorax can be classified as a mild hemothorax, moderate hemothorax, and massive hemothorax. The question here will be, what is the criteria for massive hemothorax? That is the question here. So first option is the chest tube drainage is more than 1500 ml, 1.5 liters in 24 hours. Option B is more than 200 ml of blood per hour for 2 to 4 hours. And the third option will be more than 7 ml of blood per kg body weight per hour for 4 hours. And patient has persistent hypotension irrespective of vigorous resuscitation. So, from this question, all the 4 options are the indications for thoracotomy. So, the question here is the negative question. All are the indications for thoracotomy after ICD insertion except. So, it is a negative question. Here, the answer will be none of the above because all are the indications for ICD thoracotomy after ICD insertion. So this is the chest X-ray of a patient with the hemothorax and RTA case. So of course, for exam purpose, we are supposed to know about the X-ray findings also. So let me get to it. So it is an chest X-ray PA view, and there is no rotation, and exposure is adequate here. And you can see about the bones, and you can find a fracture over here. Probably it is a shaft of the 7th rib fracture. You can have a 7th rib fracture, and of course 6th and the 5th rib fracture also is there. Of course, you know about the parts of the anatomical parts of rib 2. So this is the shaft of the rib fracture. Coming to the lung area, we should know about the lung margins, whether the lung margin has an adequate lung expansion is present or not. And the most important thing is the costophrenic angle. Costophrenic angle. Here we can see the obliteration of the costophrenic angle. Costophrenic angle is not clearly seen. And of course, you all know about the Ellis curve, which is common in the pleural effusion. Sorry for the interruption. So this is the image of X-ray with the hemothorax. You can see the blunting of the costophrenic angle and an Ellis curve here. And to know about the heart, you can see the aortic knuckle. And here is the pulmonary artery area. And this is the left atrial appendage. And here you can get an RV type of apex. This is the SVC. SVC here. AVC. And then RA here. This is the right atrium. This is about the cardiac shadow here. So we'll go to the next question, 8th question. So a 45 years old female patient presenting to the emergency room with a history of trauma. On examination, patient has surgical emphysema in the neck region. Surgical emphysema in the neck region. Clinically, how to diagnose the surgical emphysema? Clinically, how to diagnose the surgical emphysema. Here, on palpation, this can be done on palpation. On palpation, the patient will have crepitus in the subcutaneous plane. So this is the clinical feature of the subcutaneous emphysema. And how will you manage the case with the subcutaneous emphysema in the neck? That is the question here. Option A is that attempts to rule out the tracheal, bronchial, and the esophageal injury. Attempts to rule out the tracheal, bronchus, and the esophageal injury. Of course, when the air comes into the subcutaneous place or a subcutaneous plane, there must be a hollow viscous injury. So you have to rule out the tracheal or a bronchial or a esophageal injury here. And of course, video bronchoscopy to be done. There is option B. Option C is the multiple skin incisions to relieve the subcutaneous emphysema. That is to release the air. To release the air is to be done. In case of tracheal injury, we can go for intubation of the patient. We can go for intubation of the patient because if the considered is to be a trachea and there is a rent here or an injury here causing an air leak. So what to be done here? We can intubate the patient and give the air towards this area. So the endotracheal tube will occlude the rent area. So this is the emergency management of tracheal injury. So here, which of the following are true regarding the management of the above situation? So we all know that all are true here. So in case a patient presenting with an subcutaneous emphysema or the neck region, and of course the anterior chest wall, we have to rule out the tracheal and bronchial injury and also the esophageal injury, and video bronchoscopy to be done to detect the site of injury or a site of rent, and multiple skin incisions can be done to relieve the surgical emphysema or subcutaneous emphysema. And in case if there is a presence of pneumomediastinum, you should also know about this point. In case of presence of pneumomediastinum, we have to treat it with opening of the burn space. Burn space is nothing but it is the upper superior retrosternal space. Superior retrosternal space. This will be the management of pneumomediastinum. So in this chest X-ray, you can see the air in the subcutaneous plane in the neck and also in the anterior chest wall. And it is a classical collapsed lung. You can see the lung border here. Lung not expanded well. So coming to the question number 9, a 45 years old female patient, a known case of rheumatic heart disease, was admitted with a complaint of dyspnea with elevated ASO titer, that is anti-streptolysin O titer, and CRP, the C-reactive protein. Echo shows severe mitral stenosis with the mitral valve orifice that is measured by a planometer by echo is around 0.8 square centimeter with no calcification and no subvalvular fusion. So how will you manage this case? Here, the point to be noted is that patient is symptomatic. So sorry for the disruption of signals. So here the patient is symptomatic, having a dyspnea, and patient has an elevated ASO and CRP, echo showing severe mitral stenosis with the mitral valve orifice is 0.08. Based on this mitral valve orifice also, we can classify the mitral stenosis into mild, moderate, and severe. This 0.8 square centimeter comes under severe mitral stenosis, which needs intervention. But when the ASO titer and the C-reactive protein, the inflammatory mediators are positive, preferably we have to avoid open surgery. Preferably, you have to avoid open surgery and prosthetic implantation. That is prosthetic valve, mitral valve implantation to be avoided preferably when ASO titer is too high and CRP is positive. And as there is no calcification and no subvalvular fusion here, we can go for PTMC. So first you should know about what is PTMCs. PTMC means percutaneous transcatheter commissurotomy. This is called as PTMC. Through femoral axis, we will go into the right atrium, then to the left atrium, then into the through the mitral valve. We will make a incision over the commissure. So this will be the anatomy of the So here we will be going with the PTMC as the answer. That is percutaneous transcatheter mitral commissurotomy. And of course, another minimally invasive procedure is the balloon mitral valvuloplasty. You will see about this in the next slide. And what is CMC is closed mitral commissurotomy. Closed mitral commissurotomy. It is an open procedure, not commonly done nowadays. And of course, when the patient is symptomatic, we can't go with the medical management and wait to see the patient suffer. So answer will be percutaneous transcatheter mitral commissurotomy. If BVP is given, this can also be selected as answer. That is balloon valvuloplasty. So in balloon valvuloplasty, the catheter will be passed inside through the mitral valve. When the stenotic mitral valve, inside the stenotic mitral valve, the balloon will be inflated. So when the valve is very small and the balloon will be passed inside there, and it will be inflated. So this will cause opening of the mitral valve. The important complication of this procedure like PTMC and balloon valvuloplasty of mitral regurgitation can occur following the PTMC and balloon valvuloplasty. So what is the so here we are about congenital heart disease. What is the X-ray finding here? So we should know about the X-ray findings and the different X-ray findings in the congenital heart diseases. What are the different X-ray findings that can be seen in the congenital heart diseases? So here, this is the image here. You can see the inverted E or 3 sign. This is seen in the coarctation of aorta. This incoarctation of aorta, it will be associated with the rib notching. This is because of the development of collaterals. This rib notching is because of the development of collaterals. So this is how the coarctation of aorta will be. And because of the coarctation of aorta, you can get a figure of 3 or inverted E. figure of 3 or inverted E sign. And because of this, there can be several collaterals, maybe from the axillary area to the descending aorta, from a subclavian artery to the descending aorta. And because of that, there can be rib notching. Rib notching can be so. So coming to the 11th question, we still have 2 more questions. We'll rush it up. No issues. So during cardiopulmonary bypass, so next topic will be cardiopulmonary bypass. Of course, one question will be from this topic. Which of the following is true? The correct answer will be heparin should be given during the cannulation of the vessel itself, like aortic cannulation or SVC and IVC. While cannulating the aorta, we are supposed to maintain the ACT at a higher end. And the dose of heparin which routinely we practice is 300 international units. We routinely practice 300 units per kg. This is the standard thing which is supposed to answer. But of course, institution-wise, they may change the heparin dosage. But for the exams, the answer will be 300 units per kg. So the true statement will be heparin to be given during the cannulation of the vessel itself. So this is the image of cardiopulmonary bypass. The venous blood from the SVC and IVC will be circling because with the help of gravity, or siphon's effect into a reservoir, and from reservoir the blood will enter into the oxygenator, and there will be different types of oxygenators available. And from the oxygenator, the oxygenated blood will go into the pump. This pump plays a main role in maintaining the MAP, that is mean arterial pressure. And from this arterial pump, the blood will enter into the aorta for systemic circulation. This is the schematic diagram about the cardiopulmonary bypass. So coming to the 12th question about valvular heart disease. So which is the worst symptom or indicator, worst prognostic indicator for aortic stenosis? Here the answer will be, of course, all of these can occur in aortic stenosis. All are the clinical features of aortic stenosis. But the worst prognostic indicator is heart failure. This can be mentioned as a low flow, low gradient aortic stenosis. Because of heart failure, the stroke volume will reduce. Because of heart failure, stroke volume will reduce. That is, this results in low flow. As there is low flow, the gradient across the valve will also reduce. Gradient is nothing but it is the pressure difference between the valve. In case of aortic stenosis, in case of any stenotic lesion, the pressure gradient will be in the higher end. But in case of low flow heart failure cases, because of low flow, there will be a lower gradient. So this is due to reduced left ventricular ejection fraction, that is decreased stroke volume. These cases have a worst prognosis in case of aortic stenosis. So another about pleural malignancy. The most common pleural malignancy is, of course, mesothelioma. We all know about it. The most common pleural malignancy and the only malignancy in pleura is mesothelioma. Commonly, of course, we can even get metastatic lesions, but primary, coming to the primary pleural malignancy, it is mesothelioma. So in this CT image, we can see this CT scan. We can see the it is a pulmonary window, also called as a parenchymal window. Here we can see the thickening of the pleura. You can see the thickening of the pleural region. It is swelling. So these are the features of mesothelioma. Coming to the next question, how to proceed with a patient? A known case of old PTB on ATT. A case of PTB patient with ATT, complaints of hemoptysis. A patient, a known case of pulmonary tuberculosis on ATT, complaints of hemoptysis. How will you proceed? What's the investigation of choice here? Of course, we can do all these investigations. We can do all these investigations in this condition, but for localizing the source of the hemoptysis, we should go for CT pulmonary angiogram. Of course, bronchoscopy can be done to localize or to lateralize the lobe. To lateralize the lobe from where the bleeding occurs. You can visualize the site of bleeding from the bronchoscopy. Of course, iotogram and CT pulmonary angiogram are nothing but same CT images taken at different timing after injecting the dye. So in CT pulmonary angiogram, we can check the contrast leak from the vessel. And of course, we can make out the entire pulmonary artery and vein. So this can be used for detecting the source of bleeding. So the investigation of choice following a hemoptysis or a massive hemoptysis is CT pulmonary angiogram. So this is the image of a CT pulmonary angiogram showing the images clearly. You can see this is the common pulmonary artery bifurcating into the right and the left pulmonary artery, and which further divides into lobular arteries and the segmental arteries, etc. So if there is any contrast leak present here, then this may be the source of bleeding. You can go for either a lobectomy if it is very massive, or if it can be corrected, you can go for an interventional radiological procedures like specific arterial embolization. For this, we are supposed to go with the CT pulmonary angiogram. So coming to the last question, a 35 years old male patient presenting with the clinical features of aortic stenosis and echo shows subaortic membrane. How will you manage this case? So case with aortic stenosis. So aortic stenosis can also be called as left ventricular outflow tract obstruction. So the main aim of the question is that to make you read about what are the causes of left ventricular outflow tract obstruction. One of the congenital cause for left ventricular outflow tract obstruction is the presence of persistent subaortic membrane. This will be managed by subaortic membrane resection. Nothing more than that. Subaortic membrane resection can be done here. So, what is subaortic membrane? In echo, you can see the findings like this. This is the aortic cusp of aorta, and below the aortic valve, you can have a small membrane-like structure here in the LVOT. This can cause an increased gradient across the LVOT, and this can be sometimes missed or can be placed for an aortic stenosis. In this, while operating this case is very simple. To open the aorta through the aortic valve, you will see the subaortic membrane, and we will excise the subaortic membrane. It will be very simple like this. So you can see here, this is the left ventricle. So this is the subaortic membrane obstructing the flow. Here we can have the aortic valve. So through surgery, we will approach to the transaortic approach. We will go for the resection of this subaortic membrane. So the aim of this question is to make you study about the different causes of LVOT obstruction. So I have taken the time, and this will be just. And from this, what you are supposed to learn is that what are the topics that can be asked like X-ray findings, CT findings, and of course, valvular heart diseases, cardiopulmonary bypass machines, and its mechanism. You are supposed to know about it, and relax. You will get your marks for sure. All the best for your exams. The getting mark will be very easy, but making a difference in that is the most important thing. Of course, you all will do all the best, and we'll see you in the next session. Thank you, guys. If any doubt, please comment your doubts. I'm here to answer your questions, if any.